Welcome to Chill Out. I'm Pam Chill, one of the Highland Park senior producers, and I'm very fortunate today to have as my guest who I've wanted for many, many years, Dr. Ruben Weiss. Welcome. Welcome to the program. Thank you so much for appearing. I'm going to give a brief biography about you. Dr. Ruben Weiss is a graduate of Tel Aviv University, Satur Med School, trained in Israel as well as the United States. Case Western University and the Cleveland Clinic, a specialist in muscular dystrophy research with a fellow of the University of Arizona. You were on faculty at Indiana University, Purdue, and presently professor of neurology at Chicago Medical School. Dr. Weiss did also want me to add in his views are not representative of the medical school, they are his own views. Welcome, and today's program is going to be about a discussion of electronic medical records, otherwise known as EMR, or electronic health record known as EHR. Is it a hindrance or help?
Hindrance.
Alrighty. Okay, let's start with that. So, and as far as the hindrance, what would you say is providing accurate, up-to-date, and complete information about the patients and, of course, the point of care that most doctors use?
Well, there is a problem with accurate, up-to-date, and complete information in medical records. The records in a computer are just as good as the data that are fed into that computer, which is very often not up-to-date, not accurate, and certainly not complete. And many times you find actually wrong details in the record, and it's not the computer's fault. It's basically people do their own clicks.
Mm-hmm. Absolutely. And we did have a little bit, I pulled a lot of things off of the internet, that there's a lot of copy and paste going on to save time. So if you wanted to elaborate, as a physician, how if a specialist does that and another specialist comes in, or let's say the specialist is part of a group, he or she does the initial consultation, and in order to save time, how is that done with the copy and paste?
Basically what happens is very simple. You see the patient, not you, the physician sees the patient, writes down a history, physical, and all that stuff. Usually dictates it with usual mistakes that are due to the voice recognition.
With Dragon, right.
Yeah, with Dragon, right. Man up could be something different, map up or something. There are many words are the same. So after you're done with that, and they put on their conclusion, the next day they come to see the patient again. Even though not many things have changed, in order for documentation to be present, so the billing to whatever insurance company is involved has to be detailed enough. So in order to avoid clicking and all these unnecessary things that are needed for documentation, they have absolutely no clinical relevance at all. What they do, they simply copy whatever they did the previous day, they paste this as a report for this day, and then usually the last line, the impression and plan, this is the only thing that are changed. So you're faced with a situation, and that happens in hospital usually, not so much in private practice, but in hospitals, that all the notes from day to day are identical. The only difference is the last few lines, the impression and the plan, which is pretty much what counts. Because a lot of medical records is basically data entry processing for billing purposes. The whole EHR today, unfortunately, is a billing machine and documentation machine with some clinical stuff attached to it, but it was never designed by mistake or by perhaps on purpose to be a tool, clinical tool for physicians. It has been designed to be more of a documentation billing system that benefits the hospitals.
The hospital and the coding to be coded correctly.
Exactly.
Right, absolutely. Yes. And then we go on to the topic of enabling quick access to patient records for more coordinated, efficient care.
It does enable quick access to the patient care. but it does definitely not help to coordination and efficiency, simply because one of the major things in medicine that help in terms of diagnosis is verbal communication between physicians, because a lot of information happens, a lot of knowledge appears, a lot of brainstorming and diagnostic criteria appear when you talk to somebody and you discuss a case person to person, face to face. One person brings up one option, then you have to discuss that, and the direct contact between physicians that it's so productive in helping find the right diagnosis and treatment, it's gone. So it definitely doesn't improve efficiency of care there. It deletes it because people are not really interacting person to person anymore. Phone calls from your consulting doctor to your primary doctor still occur if the consultant is a nice guy, or the case is very unusual, but most of the time there's no contact anymore.
Mm-hmm. No, so that is very true. And then when we go back to the notes, unless they have a scribe, they're really spending more time, just facing the computer and making sure they're accurately spelling everything and coding everything that they've checked on without actually giving sometimes a very thorough examination, as you're saying, eye contact and history of the patient. So, those are things to touch on. So we did also discuss at lunch securely sharing electronic information with patients and with other clinicians.
Well, sharing of the records is another interesting story. We have some recent research I found about a week ago from Journal of Medical Economics, actually last week, so it's very fresh information. And basically they polled a few thousand doctors, and the question was if the EHR has improved system ability to share records. And the answer is no. In 69% of the cases, which is kind of interesting statistics. And I found a very interesting cartoon that shows the in a way, descriptive way, how interoperability of medical records work.
Yes.
I'll just read it.
Funny. Yeah, we can read it.
And it says, what if traffic control devices were developed like electronic health records? And it says, traffic is backed up for 2 miles on Main Street because we have 25 traffic lights developed by 25 different vendors.
That's right.
And each uses its own timing and color scheme. On one corner, green means go, while on another it means stop. And some lights have five phases, others only have one. We could get some of them to work together, but we cannot afford the upgrades. They appear to be sabotaging each other to prevent any communication attempts. The railroad crossing is a different disaster because the gates and lights are from different companies and neither communicates with the railroad, but it does come with a nice mobile app. So basically the problem is that the systems do not talk to each other. And the question is why? And for example, to go back to the statistic, the interoperability score, 1 to 10, the physician rated it as 3-point-something, 3.9. And this is very simple. The records don't talk to each other, which was one of the main premises, that the records will talk to each other. And the reason for that is very simple. We have different health systems.
And different computer systems,
which
completely.
Yeah,
right.
and, but you could make different systems talk to each other if you wanted to.
Right.
But each system competes with the other. So why would health system A, consisting of 3,000 best physicians in the United States, want to give its personal data of his patients, of his customers, to system B that is the prettiest health system in the United States? I mean, why you want to give your competition your customer database? I don't think any.
No, and then we have HIPAA, we have confidentiality, and then we have we have upgrades. Even though there is sometimes a similar system or same system, one has been so upgraded because it's a new system and another hasn't. So, I mean, how can it's
that
getting
brings
to be
up a very interesting thing, and how many systems people have. And the statistics are very interesting because the average of systems a medical practice goes through, it's 3 systems. For example, how many EHR systems have you personally used? And 26% have used 5 to 7 systems.
That's a lot of systems. Yes, it's a lot of, yeah.
The 6% have
Absolutely.
used more than 15, which is basically incredible. And we talk about how much it costs. Basically, the average annual cost of a system is $44,500 with a median of $29,200. That explains to some extent why we don't have so many independent physicians anymore. Because the computer system cost, when you spread it across a group of 10 physicians, it's much cheaper than if you're by yourself and you have to fork out $22,000. They have 10 people, it's less, it's $2,000 per person. So
right, but if you're a sole practice, then you're incurring all that cost.
This is a regulation that basically EHR, and you have to use EHR, otherwise you get penalized.
You get penalized by you're at 7% from Medicare,
Yes.
right?
And
that they'll take out of every single Medicare check will automatically be deducted.
Yeah, and that will keep going on. It'll deduct more and more.
Right, each year it's going to be
so
more.
This has
into
the
process.
EHR has been a very strong incentive in the death of the independent private practices in solo private practices in the United States. For example, 15 years ago, about 2/3 of the patients, half to 2/3 were in private practice. Today it's down to maybe 10%, if that. That's going to disappear too. Your family physician that knew you since the day you were born and knew your children and your grandchildren, and you called him on the phone, he could tell from your voice if you're sick or not. It's history.
Or take one look at you when you walk into the examining room that you're not yourself.
It's
right.
done. There are no more. There won't be any.
We don't have the Marcus Well BMD anymore. That's for sure.
No.
Already, absolutely. So, Dr. Weiss, we're talking about securely sharing electronic information with patients, other clinicians, and on that, there have been numerous lawsuits about compromised information, and if you wanted to touch on that about hacking, and to do that too as well. So. But we also talked about helping provide more effectively to diagnose, to reduce medical errors, and provide safety and safer care of patients. So how do you think the electronic medical records does with medical errors?
Well, Pam, you touched on a few points, medical errors, how secure they are medical records. And I would say, first of all, let's address the security of medical records, because if you want information of somebody, their social security, their address, their birthday, their everything, the best place to go for is medical records, because everything is there. And that doesn't work too well. About 58% of physicians are very concerned about the security of the data in their HAR system and potential to be breached. And that statistics from last week, 4% of the practices have been victims of a data breach in the last 12 months. 29% were not sure because you don't know.
They haven't found out yet, right?
Yeah. Only 70% or so, 76% felt that were safe. So 4% doesn't sound very much, but when you have 200,000 doctors, that's quite a few practices. And the interesting point is what were the top causes. Turns out that ransomware is probably one of the major things. And we all read stories in the news about hospitals being, being basically hacked in with ransomware installed. The others are opened email with phishing scheme, hacking, the malware installation, employee sometimes they steal data too. The second question I think you asked was in terms of, can you refresh your memory what it was?
Right, about diagnosing more effectively diagnosed
okay.
patients and reduce, about mainly medical errors.
Okay,
Yes.
medical errors, it's also an interesting thing because computers actually do not prevent medical errors the way we would like them to. And it's very easy to click on the wrong little thing in the computer than actually make an error when you write stuff. When you write a prescription, it's really very easy to click instead of 10 milligram on 20 milligram. And they're both okay. There's no health risk associated with it. But in terms of the patient, that will make a big difference. Probably the most pernicious effects of medical records are spending too much time entering data in the computer and not really basically dealing with the patient, relating to the patient, dealing with actual patient care. And we are all very familiar, including myself. When I go to my family doctor, basically his nose is in his laptop or device, and he clicks vigorously on all these bullets, and he barely looks at me. So it's normally the odds of being even touched or examined are very microscopic. If anything, maybe they'll touch with the stethoscope. I think it's a very common experience these days.
Oh, absolutely,
So that,
without a doubt.
That personal touch, which I think is a big part of healing. A big part of healing is actually a personal touch from the physician. The care, the empathy, the interest in you are very important. Mm-hmm. Very important. And unfortunately, I kind of knew that the thing were up when they started talking about physician productivity. Now, what's a physician productivity? Is the physician that sees 20 patients an hour, spending 3 minutes with each patient, and making quite a bit of money for the insurance company, more productive than the doctor that spends half an hour, comes up with the right diagnosis, treatment, and the patient goes home happy and his health is improved. I think, to me, productivity is more, the second physician more productive, but since today we live with the business model of medicine,
it's a business model of
the
medicine,
first
absolutely.
doctor
Yes.
is productive. So it's a different problem, and I think medical records have exacerbated that productivity issue because it's becoming an industry of medicine. Yes.
Absolutely. I just wanted to touch on a couple of things that I did pull from the internet as well. About the charting, and attorneys have said that, how attorneys review a medical malpractice cases through the audit trail. And they said what's happening now in medical negligence litigation is that, before, when it was paper charts, you would have the paper, and now it seems like everybody, all the nurses all the attorneys have said this, a lot of attorneys, is they're going back and they're putting in their notes after things have happened. Not as they're happening, but that's how they're charting. And what used to happen on a chart, a real chart, a paper chart, is they would put the time and initial it. And now that they're going back, they don't really have a good time. I don't know if it's not showing, a time frame that things are happening. So they said it's very difficult for them to go back and to try and audit a paper trail of a case that's gone bad. So I just wanted to add that into that from the attorney's viewpoint. So we also wanted to touch on improving patient and provider interaction and communication, as well as healthcare convenience. You talked about not talking to each other. Yes. So why has this all changed, where the specialists and the physicians, even they can be in the same office, they can be, meet each other at different meetings, and there's really no communication, unless they have some kind of relationship with the person about a case. They're kind of just like, reading the notes, and then that's it. What happened to the communication? Any ideas, any thoughts? Or
Well, Pam, first of all, I have to admit I feel extremely sorry for the attorneys. I have very little sympathy for these guys that sue doctors. I have to admit, occasionally there is good reason for malpractice and the lawsuit is justified. The majority of cases, they just, try to make some money on somebody's misery because they get 30% of the settlement.
That's absolutely
And
right.
many
yeah.
times hospitals, doctors will settle just to avoid the hassles of years of litigation. As far as why there is less verbal communication between doctors than it was, I have no answer for that. I just don't know.
Yeah.
It's maybe an issue of culture.
I
Because
think
the
that's
younger
it,
doctors
yes.
coming out, they have different criteria. But in general, we know that today there is actually a problem with teenagers, for example. They are less communicating with each other. They basically use their little
Right.
communication
right.
devices, talking to each other by,
Very little verbal
Yeah,
communication.
so
Absolutely.
maybe it's part of this situation.
Absolutely. Okay, then we
But I-
want to touch on, excuse me, if you have a thought, you're just intervene. Just, safer prescribing. Now, because it's also the e-scripts, so everything is, on e-scripts. You wanted to touch on that.
Well, I don't think, first of all, as far as prescribing, it's a total and complete disaster. Before, it used to take me exactly 2 seconds, 3 seconds maybe, to write a prescription. Patient's name, date, medication, signed. Now, it takes basically 2-3 minutes with 20 clicks just to prescribe an Ambien or an aspirin. It's insane. With all these quote interactions that, and they're not useful. I mean, as a physician, for God's sake, you know what goes with what. And any medication has its risk. Any medication has side effects. Medication is not candy. So every medication has side effects at risk associated, and you take chances. You choose the smaller evil, so to speak. So, and all these warnings are basically unnecessary because we know there's a problem, and we know there is a risk, but we accept that. So the reason for all these warnings are more to kind of cover certain people's, rear end in certain systems, but we know that we take a chance. And it's also easier to make an error when you click on the wrong amount.
Right. When you're writing it, you take a look at it and you look at it. When you're entering
Exactly.
it's...
Absolutely, and I used to actually print my prescription to prevent any problems due to handwriting. So they're all printed in big letters, big numbers, and furthermore, I would give my prescription to my nurse. So she would look at it, make sure, double check on that.
Double check and review,
Yes, have two
right.
people looking at the same thing, but with a computer you click. And I felt sorry for my physician that I saw 3 weeks ago. I needed all my prescriptions redone and asked him to print them out. And there were 8 of them because I'm getting, of course, younger and prettier, so I take more medications. And the poor guy took him like at least 10 minutes to print out my scripts. It was sad to watch him do that. So instead of taking care of me, looking at me, discussing my issues, he was.
That's right. And of
Yes.
course, being a physician who types 80 words a minute as opposed to the one who types about 20, it's another, obviously, setback if you're not good at that as well. It takes longer. We also want to talk about streamlined coding and billing. So I know we touched on that a little bit. Did you want to add anything to
About
that?
coding?
About coding and billing?
Uh,
I know if somebody is on like the borderline, obesity, you always go with the designation for the coding. That's what hospitals want you to do, right?
Yes, this is another funny thing. Instead of having diseases, we have codes.
Right.
You don't have a heart attack, you have 240.7. Well, at least it used to be like that.
Uh-huh.
So that was a certain system that we had, I think, 12,000 different diagnoses. Not good enough for the bureaucrats, so they changed the system. And now we have 100,000 different diagnoses.
Yes, absolutely. Yeah.
If you break your left hand, it's one code. If you break your right hand, it's another code. If you break your right hand while you sleep on ice, it's a different code than if you break your right hand if you're hit by a car or if the dog bites you. So, and all this coding system, it's an insane system that's mostly designed again by bureaucrats for billing and documentation purposes.
Right.
Because this way they can tell, what diseases supposedly are in the, floating around, but it has really no clinical significance because people have to, not have to, but they manipulate that to get a more severe code and get paid better.
Absolutely.
So it's basically a system that has no really clinical purpose. It has only a business purpose.
Mm-hmm. Absolutely. So I did want to touch on too, reducing costs through decreased paperwork, improved safety, and there's so many still duplication of tests. I mean, in this, any thoughts on that? Yes?
Pam, you're putting gasoline on the fire. It's a topic that gets me going. Yes, it hasn't diminished at all the requirement for paper. In fact, since the medical records, we are cutting more trees than we used to. Things still have to be printed out. A good example is the medical records requested by lawyers, or if you request your own medical records from the lawyer, from your doctor, and prints them out. Before, basically, you would get a small package if you were his patient for 5 years, maybe, maybe quarter of an inch. Now, for 1 year, you get a whole package of useless printouts, and you have to kind of go through them and kind of figure out what's relevant and what's not. Mm-hmm. And if you get the records from the hospital, you get also nursing note mixed with that and lab notes. So you probably need a wheelbarrow if you're in the hospital.
It's a lot of records. It's a lot of paperwork.
Yeah,
a lot of
there's
records.
no efficiency in terms of saving expenses. And I already talked about the expenses of having a system that's average of $30,000, and also the problem that you have to change systems all the time and the upgrades, and people are not happy with one system, they try another one, they're not happy with that.
Or you have to be hooked onto the hospital. So when the hospital upgrades too,
then you are required
to upgrade as well, because you can't get any data. You can't get the tests that were done, and you can't get the hospitalizations that were done. So it's just this endless vicious cycle of doing that. And how does one have work balance and home life when you're doing that?
Well, this is a sad situation because the patient's life balance and home life has basically deteriorated significantly. And sadly, the medical records have had a very negative impact on people's quality of life. Looking at the statistics, they are very sad.
And burnout.
It is known that the burnout, one of the causes of burnout of physicians is actually medical records. It is estimated that about 25% of the burnouts are related to EHRs, to electronic health records.
Right, because if they can't get it done in the office, they have to take it home with them.
Yeah, and they have to spend time at home and in the office doing hours of basically data entry that has no clinical relevance. And this is not why we are there. We are here to help people, to cure people, not to do data entry processing for some.
They're telling me that it's time to, I thank you so much for your time, Dr. Ruben Wise, and you become a really advocate for the disadvantages of electronic medical records.
Can I stop you for a moment, Pam?
Sure.
Not so much. We need a new chart. We need a new
system.
EHR